A very good afternoon to all. First of all, I would like to thank MAPICON faculty and especially Dr. Vitull for giving me this opportunity to speak on this platform. So for the next few minutes, I'll be speaking regarding the diagnosis and management of hypercalcemia. As we know, hypercalcemia per se is not a disease. It's rather a manifestation of underlying disorder. So a prompt diagnosis and management of that disorder is very crucial so as to prevent the end organ damage, because untreated hypercalcemia can lead on to acute kidney injury. It can also cause cardiac arrhythmias, which can be fatal sometimes, or it can have neurological implications. Can I have my slides, please? Not even. Oh, I think. Can you please? Slides मेरी नहीं है. So hypercalcemia is defined as level of calcium that is above 10.5 milligram per deciliter. Normal concentration of total calcium is 8.5 to 10.5. So coming on to the etiology of hypercalcemia, etiology is broadly divided into two categories. One is PTH dependent, another one is PTH independent. So in the PTH dependent category, there is excessive autonomous secretion of PTH. And the most common cause of PTH dependent hypercalcemia is primary hyperparathyroidism. And then tertiary hyperparathyroidism, FHH, and lithium therapy can also lead to PTH-dependent hypercalcemia. Now coming on to PTH-independent hypercalcemia. It occurs due to malignancy, granulomatous disorders, multiple myeloma, and it can occur as a part of vitamin D intoxication. And certain medications can also lead to hypercalcemia. I'll be discussing this in detail. So the first step in the evaluation of patient with hypercalcemia is to confirm whether the patient is really having hypercalcemia or not. So we have to check the corrected calcium levels or ionized calcium level to confirm whether the patient is really having hypercalcemia or not. And the next step, which is most important step in the evaluation of hypercalcemia, is to do PTH level. I have seen many times in our institute also, when a patient comes with hypercalcemia, residents write a battery of tests, including PTH, serum protein electrophoresis, ACE levels, CT chest, CT abdomen, maybe for looking for malignancy. But the first and foremost step is PTH, because this can avoid many unnecessary investigations. So after doing PTH, if PTH level is elevated or even normal, because a level of 20 is taken as cutoff. If PTH is above 20, it means that hypercalcemia is PTH dependent. Because in patient who is having PTH independent hypercalcemia, due to any cause maybe, we expect PTH levels to become undetectable as a normal response of the body. So if the PTH level is above 20, even if it is in the normal range, it is PTH dependent hypercalcemia. And the most common cause of hypercalcemia overall is primary hyperparathyroidism and malignancy related hypercalcemia. So in this category, it is primary hyperparathyroidism which is most common. Again, coming to tertiary hyperthyroidism, we have to check creatinine levels. If the creatinine levels are normal, patient does not have CKD, tertiary hyperpara is out. So then again, it remains primary hyperpara. Third, which is the rare cause, familial hypocalciuric hypercalcemia. In patient who is having hypercalcemia due to any cause, we expect 24 hours urinary calcium to be high. But in this scenario, 24 hours urinary calcium is low. So by doing 24 hours urinary calcium, we can get an idea. But if a patient is having PTH dependent hypercalcemia, more than 95% patient will be having primary hyperparathyroidism. So we should focus on this etiology and to diagnose primary hyperparathyroidism. And more precisely, to localize where parathyroid adenoma is, we have to do a battery of tests, which include ultrasound is considered as the initial best test for the evaluation. Ultrasound neck has got 60 to 80% sensitivity. Then technetium system VB scan, which has got sensitivity of up to 85 to 90%. If we are not able to localize adenoma, with ultrasound and even technetium system EB scan, which is a common scenario, sometimes happen in clinical practice, that we have a patient with hypercalcemia, PTH is elevated, ultrasound is normal, technetium system EB scan does not show any adenoma. Then the next best investigation is to go for PET choline scan, which is not available widely. In our region, it is only available at PGI Chandigarh. I don't know whether it is available in AIIMS Bathinda or not, but in Ludhiana it's not available. So, but this with this test we can diagnose primary or we can localize the adenoma in up to 95% of patient, and this test has got a specificity of 80 to 100%. And again 24 hours urinary calcium creatinine ratio when we are suspecting FHH. But in familial hypercalciuric hypercalcemia, the calcium level will be mildly raised up to 11 or 11.5, and patient will have a history of long-standing hypercalcemia. If you have calcium level of 13 or 14, FHH is out. It's primary hyperparathyroidism. We need not to go for 24 hours urinary calcium creatinine ratio even. And again, the second scenario when PTH is not elevated or PTH is undetectable. That is PTH is less than 20 picogram per ml. Then we have to perform certain tests to get into the etiology, and 25 hydroxy vitamin D levels are elevated in vitamin D intoxication. So the best is to go for 25 hydroxy vitamin D, a chest X-ray, ACE levels as an initial investigation in these cases. If ACE is elevated, we will think of sarcoidosis. 125 dihydroxy vitamin D levels we don't routinely do, but in certain scenarios where we are not able to exactly diagnose the condition, we can take the help of this test. This is elevated in sarcoidosis, lymphoma, and tuberculosis. In patients who are having granulomatous disease, there is activation of 1-alpha hydroxylase enzyme which results in increased levels of 125 dihydroxy vitamin D. Again, there is a scenario when there is normal vitamin D levels and PTHRP levels. Then you can evaluate for multiple myeloma. Milk alkali syndrome remains the cause. But among patients who have PTH independent hypercalcemia, CT chest, CT abdomen, and a PET scan is done to evaluate for hypercalcemia of malignancy. Given an option between PTHRP and a PET scan, I would choose a PET scan because PTHRP is a very costly test, and a PET scan is very good to diagnose any occult malignancy which is resulting into hypercalcemia. So if PET scan is negative, despite doing all investigation, CT chest, CT abdomen, PET scan, we are not able to localize where is the etiology of hypercalcemia, then we can go for PTHRP levels. Otherwise, in routine clinical practice, we don't normally do it. So there are certain subtle clues to the etiology of hypercalcemia which can guide us in ordering an investigation or avoiding some unnecessary investigations. So presence of long-standing asymptomatic hypercalcemia is more common with primary hyperpara and FHH, familial hypocalciuric hypercalcemia. FHH is a very rare condition. Chances of primary hyperpara are more likely. But if a patient has mild hypercalcemia and patient gives you history of hypercalcemia in first decade, suppose a 30 years old male comes to us and the parents give that when the patient was 5 or 6 years old, he was also having hypercalcemia at that time, diagnosed slight hypercalcemia. So it is FHH. It is not primary hyperparathyroidism because FHH patients can have hypercalcemia during first decade of life. Again, hilar lymphadenopathy, uveitis, elevated ACE levels, or elevated 125 dihydroxy vitamin D levels point towards the diagnosis of sarcoidosis. High ESR, anemia with renal failure, and lytic lesions on chest X-ray do point towards multiple myeloma. A patient who has hypercalcemia with suppressed PTH level, elevated 125 dihydroxy levels, lymphadenopathy or mass lesions, or weight loss, elevated LDH with hyperuricemia, we have to keep the possibility of lymphoma because lymphomas can present with hypercalcemia. And hypercalcemia with suppressed PTH levels, elevated PTHRP, weight loss, bone pain, evidence of metastasis, it's hypercalcemia of malignancy. And again, another scenario where hypercalcemia is there, but PTH is suppressed, normal 125 dihydroxy vitamin D levels, but there is history of excessive intake of vitamin D injections. So it is vitamin D intoxication. And another rare entity which is characterized by alkalosis, renal failure, and hypercalcemia with a history of recent ingestion of calcium and alkali supplements. This is milk alkali syndrome. Not seen commonly nowadays, but 2 to 3 decades before it was quite common. So I'll take you through various real case scenarios which we have encountered in our hospital. First case scenario is of a 52-year-old male who presented with pain abdomen for 2 days, sudden in onset, associated with multiple episodes of vomiting. Vitals were normal, examination normal, except for mild tenderness in the epigastric region. On investigation, amylase lipase levels were elevated. Corrected calcium was 11.5, PTH was 50. And it was within normal range. Seeing these levels, we made the diagnosis of primary hyperparathyroidism presenting as acute pancreatitis. It's an uncommon manifestation of primary hyperparathyroidism. And the resident asked me question, why we made the diagnosis of primary hyperparathyroidism despite normal PTH level. So the answer is clear. When PTH level is more than 20, because in any patient with hypercalcemia, we expect PTH level to be undetectable if it is PTH independent. So the level was within normal range, but it was inappropriate for calcium level. So the diagnosis was primary hyperparathyroidism with acute pancreatitis. Ultrasound neck did not show any adenoma. Technetium system EB scan showed right inferior parathyroid adenoma, because sensitivity of technetium system EB is more as compared to ultrasound neck. So this is the picture, and the arrow is showing right inferior parathyroid adenoma. Patient was given IV fluids and calcitonin. The protocol for giving IV fluid is 200 to 300 ml per hour for the first 24 hours. And we try to give 3 to 4 liters of fluid in the initial 24 hours if the patient is not having any evidence of fluid overload. Then, but calcium levels did not normalize. So patient was given zoledronic acid 4 mg and calcium level normalized on third day of injection. After zoledronic acid, it takes 2 to 5 days to normalize calcium level with zoledronic acid. It does not act immediately, whereas calcitonin acts immediately, but it's not a very potent agent. So endoscopic left inferior parathyroidectomy was done after 4 weeks. After resolution of acute pancreatitis, intraoperative PTH levels dropped down. Postoperative day 2 patient developed hypocalcemia, given calcium gluconate, normalized in 3 to 4 days. So primary hyperparathyroidism masquerading as acute pancreatitis is an uncommon manifestation in Western world, but here in our country we do see it commonly. And this is a case series from our institute where we took the data of 30 patients who had acute pancreatitis with primary hyperparathyroidism and compared them with those who had primary hyperparathyroidism but did not have acute pancreatitis. The results showed that patient with PTH, primary hyperparathyroidism associated pancreatitis, has male preponderance, whereas primary hyperparathyroidism has female preponderance. They were having higher calcium levels and lower frequency of skeletal involvement as compared to those without pancreatitis. And presence of nephrolithiasis was associated with severe attack of acute pancreatitis in these patients. A second scenario presented similarly with pain abdomen, vomiting. Examination was almost normal. Again, we did the investigations. PTH was low. It was 4.78, less than 20. It means it was PTH independent hypercalcemia. Vitamin D levels were elevated more than 174. If vitamin D levels are more than 150, it is considered vitamin D intoxication. And creatinine level was 3.1. So the diagnosis of vitamin D toxicity with hypercalcemia with acute pancreatitis. All other causes of pancreatitis were ruled out. In this patient, we published this case report also because it's a very uncommon manifestation of vitamin D intoxication. And in this patient, we gave IV fluids and calcitonin. The drug of choice for vitamin D intoxication is steroids. 30 to 40 milligram of prednisolone is given generally for 2 to 3 weeks. But in this patient was having acute pancreatitis. So steroids were relatively contraindicated, not absolutely. It is gray area whether to give steroids in such cases or not. But in this patient, we gave denosumab to be on the safer side. And because zoledronic acid could not be administered due to EGFR was less than 35. So denosumab 60 milligram subcutaneous was given and calcium level was normalized on the 4th day in this patient. And the third case scenario, it's of a 65-year-old woman brought to the emergency department with irrelevant talk and drowsiness for 5 days. History of backache was present for 1 month, and general physical examination and neurological examination was essentially within normal limits. Investigation showed creatinine levels of 3.9, calcium of 16.1, and alkaline phosphatase of 550. PTH was less than 20. It was 7. So it was PTH independent hypercalcemia. Detailed examination revealed small lump in the left inferior quadrant of the breast. So possibility of malignancy associated hypercalcemia was kept. FNAC from the breast lump was suggestive of breast carcinoma. MRI spine showed thoracic vertebral metastasis. So the diagnosis of breast carcinoma with thoracic vertebral metastasis with hypercalcemia was kept. IV fluids calcitonin were initiated, but calcium remained very high. So denosumab 120 mg was given in this patient. For malignancy associated hypercalcemia with skeletal metastasis, we do not give 60 mg dose, we give 120 mg dose, because 120 mg of denosumab has been shown to prevent skeletal related adverse events in patients with skeletal metastasis. Patient developed bradycardia and AV block next day. The effect of denosumab or zoledronic acid comes after 2 to 3 days. But in this patient, on second day, patient was having hypercalcemia and was having arrhythmia. So urgent hemodialysis was done using low calcium dialysate. This is another modality which is done in emergency situation, and the calcium level normalized with this. So denosumab inhibits bone resorption. 120 mg is preferred over 60 mg in patients with skeletal metastasis, and no dose adjustment is required in renal failure. So again, this is the article we published with patients who presented with hypercalcemic encephalopathy. The most common cause in patients who had hypercalcemic encephalopathy was malignancy. Otherwise, the most common cause is primary hyperpara. But in this series, hypercalcemic encephalopathy malignancy was the most common cause, because encephalopathy is not common in patients with primary hyperparathyroidism because of gradual rise in calcium levels. In malignancy, there is rapid rise in calcium levels which can lead to encephalopathy. So that's why malignancy associated hypercalcemia was most common cause in this series. Now coming to the last case, this is a case of 51-year-old female presented with nausea, vomiting and weight loss. 4 kg weight loss was reported in 2 months, and blood pressure was normal. Patient had tachycardia. Oxygen saturation was 98%. On investigation, serum calcium was 12.4, creatinine was 1.3, PTH was less than 18. So it was PTH independent hypercalcemia. ACE levels were elevated. It was 121. So we got a call from gastroenterology department for this patient. They worked up this patient for sarcoidosis. CT chest revealed thymic hyperplasia, but there was no mediastinal lymphadenopathy or parenchymal involvement. Patient did not have uveitis. So again, when we examined the patient, patient was having fine tremors, tachycardia, thyroid profile was ordered, and free T3, T4 was elevated, and TSH was suppressed. Technetium scan suggested Graves' disease. And this is a picture of technetium scan, which is suggestive of diffuse uptake, suggesting Graves' disease. Hypercalcemia is not a very common initial manifestation of Graves' disease. It can occur in 10% of the patients with Graves' disease. So this patient was treated with carbimazole 30 mg per day and propranolol 40 mg per day. After 4 weeks, free T3, T4 levels and calcium normalized. And after 3 months, ACE levels turned out to be normal, and repeat CT showed no evidence of thymic hyperplasia. So the lesson we learned from this case was that ACE levels can be elevated in patients with thyrotoxicosis, and even thymic hyperplasia can occur in these individuals, which revert back to normal after the treatment of hyperthyroidism when patient returns to euthyroid state. So the take-home message include initial evaluation should include confirming hypercalcemia with corrected calcium or ionized calcium, followed by assessing PTH level to determine whether it is PTH dependent or independent hypercalcemia. IV saline is the first line treatment. Zoledronic acid or denosumab are preferred treatments for malignancy associated hypercalcemia, particularly in patients with skeletal metastasis. Denosumab is considered slightly better in this situation. Calcitonin provides a rapid but transient reduction in serum calcium levels, and tachyphylaxis occurs within 24 to 48 hours. Steroids are effective in granulomatous diseases, lymphoma, and vitamin D intoxication. Steroids have no role in patients who have hypercalcemia due to primary hyperparathyroidism. These patients, we use zoledronic acid or denosumab to normalize calcium level, and ultimate treatment is removal of the adenoma. Dialysis is used for severe life-threatening hypercalcemia. Thank you.
Thank you very much. Again, a beautiful talk about very less talked about issue. So when you suggested, I readily picked up, because in a lot of lectures or conferences I attend, hypercalcemia is never talked.
Yes.
So thank you very much. And I want to ask you, in your practice, how many people of hypercalcemia you encounter with now very prevalent intake of vitamin D and calcium, oral intake?
Oral intake of, sir, with oral intake of vitamin D, we don't encounter much patients with hypercalcemia. But with injectable vitamin D, we do frequently encounter patients with vitamin D intoxication, and that too with vitamin D injections. With oral, one or two patients, I would say, out of 50 to 60 patients we have seen. We are also doing a study with Dr. Naveen Mittal in DMCH. I was also doing with sir, clinical profile of patients with D intoxication presenting with hypercalcemia. I think we are having 30 patients. We have enrolled 30 patients, and we are looking into the clinical profile of those patients. And most of the time, the patients who presented with hypercalcemia, they had received vitamin D injections
Injections.
from, and the most common department from where they received was orthopedic department. What did
Because
we
now
have?
vitamin D is being considered as, Panacea of all diseases.
Yes,
You
sir.
take vitamin D, and I don't know what was happening 40 years back when we were students. Then the population did not have vitamin D deficiency. Now it is, thought that about 80% of Indian population
Yes,
is
sir.
vitamin D deficient. So
Truly.
everybody is after taking vitamin D.
True,
Thank
sir.
you very
True.
much.
Thank you. Thank you, sir.